I will take the history in a child. Directly, we are jumping towards the examining of the patient. And the most important thing, okay, what I'm telling is, being an optometrist, the most important thing that we need to know in a child is how to assess visual acuity in a child. So there are different ages of the child, right? There will be a baby, there will be a toddler. How we will take visual acuity of these children? So the preferred method of testing visual acuity in a 4-year-old child is
I
one of
will
the
take
following
the
charts.
history in a child. Directly, we are jumping towards the examining of.
Okay, so there's a 4 years old child. So the 4 years old child, okay, you won't be able to read, write. Okay, it will be very difficult for him. So even if he knows ABCD at home, but when he comes to your clinic, he will be feeling shy, or he will be telling you exactly, okay, ABCD 1, 2, 3, 4, like that. So the best option will be HOTV. So the answer is HOTV matching. Okay, I don't know whether you are hearing me or not. Can you tell me you're hearing me or not? If I get a message from someone, then that will be better. Hello, Kapil sir, is it audible?
Yes, sir.
Okay, fine then. So, so the second thing is, what is the importance of HOTV chart? Okay, what is the importance of HOTV chart? So sometimes you'll be asked the MCQ regarding the Down syndrome children. There will be some children that are those children have the developmental delay. Okay, uh, some neurological problems in those children. They are not able to speak, they are not able to write. Okay, physically challenged kind of children, mentally retarded kind of children. Okay, those children, they can see properly, but they are not able to speak, they are not able to start a conversation, they are not able to give you any response. For those kind of children, they can easily match the visual acuity, right? So in those cases we can use HOTB. So H, there will be four letters, HOTV. Sometimes H will be shown, sometimes O will be shown, and the child should match those letters on a piece of paper that is given to him, or a small kind of board, okay, that is given to him, where there will be four letters, HOTV. Yeah. So the another question with this chart is, why we can't use other letters except H, O, T, and V? Okay. So what is the reason why we are using only H, O, T, and V? Okay. The answer is, the mirror image of these letters is same. Okay. If you take the mirror image of other letters, the images will come different. But when you are looking at the mirror image of H, O, T, V, all of them are same. Okay. So that is the reason the children are not confused. Mentally retarded children often get confused with the letters. That is the reason they don't want to tell you, or they don't want to give any answers regarding the letters. So if you are giving HOTV, they are not confused with the letters. But the second question will be the preferred method of testing visual acuity in a 8 months old child. Okay, 8 months old. Look at the age. So first of all, when you are assessing a visual acuity, you should consider the age of the child. So in a 8 months old child, already the accommodation will be developed, right? So in a 8 months old child, the convergence will also be there. The uh, tracking will be there, right? So the fixation will also be there. So the 8 months old child, what is the best method of assessing visual acuity among these four? Commonly he can do, Ellen also he can do. Ellen has the pictures, right? HOTB also matching, okay, 8 months old, okay, that's impossible. So the TAC means tailored acuity cards, right? Preferential looking test. Yeah. preferential looking this, you have to occlude one eye, and then you are, with the other eye, you have to look at the fixation, whether the eye is moving towards the greetings or not. Okay. Fine. So the following undergoes emmetropization. You know what is emmetropization? Okay, most of the times you will get one MCQ regarding emmetropization. So whenever a baby is born, okay, he has some refractive error. Why he has some refractive error? Because his eyes are small, the eyelids are tight, okay, and those eyelids are pressing the cornea. Even the eyeballs are small. Because of this reason, he will be having some refractive error. So the okay, what is the trend of the refractive error? Okay, those children, they will have only hyperopia and myopia, or those children will have hyperopia, myopia, astigmatism, amblyopia, or those children will have hyperopia, myopia, or astigmatism, or hyperopia. Okay, so which of the things will emmetropize? That is the thing, right? The answer will be C: hyperopia, myopia, and astigmatism. Yeah. So the children in the first year of life have a high prevalence of rate of significant adult astigmatism. Yeah, when a child is born, there will be astigmatism. Got it? Yeah, you will have some amount of the astigmatism, you will have some amount of the refractive error. There is no doubt about it. Fine. So what is the type of the astigmatism that the child will be having? With the rule astigmatism or against the rule astigmatism?
Against.
Okay, with the rule astigmatism. Okay, fine. So another interesting thing regarding the geriatric optometry, I will tell you one thing. Okay, so the similar question: why they will be having with the rule astigmatism? Tell me. Because if you look at the eyelids of a child, okay, those eyelids are tight, right? Yeah, the eyes are small. Because of that reason, they will be having the tight eyelid. So those eyelids will press the cornea radially like this. Okay. So after pressing the cornea radially like this, they will be having with the rule astigmatism. So uh, in a geriatric optometry, what happens after cataract surgery? Okay, you might have seen a patient with cataract surgery. Sometimes you have to put suture in that patient, right? In the cornea, you have to put suture here, right? So when you are putting a suture, the suture will be towards towards the 12 o'clock, 11 o'clock, or 1 o'clock. Only in these three positions, the preferred position of putting a suture after cataract surgery is 11 o'clock, 12 o'clock, or 1 o'clock, right? So after cataract surgery, or sometime, or you have to make an incision. Okay, forget about suture. You have to make an incision. When you are incision means when you are doing a cataract surgery, you have to make a small hole, right? You have to cut the cornea and you have to make a small hole. So when you are making a small hole, and put the device inside the anterior chamber of the eye, the preferred position of putting making suture, making a small hole is from the 12 o'clock or 1 o'clock position, right? So after surgery, when you are doing a refraction of a patient, the refractive error that you will get is 90-degree refractive error, right? 0.5 90 degree, 190 degree, like that you will be getting astigmatism. Why? Because if you are putting a suture or you are making a small hole over there over the cornea, the cornea becomes flatter. Got it? So that is the reason. So which type of retinoscopy is mainly used for determining the refractive error of the infants? Okay. So what do you say? Bell retinoscopy, chromoretinoscopy, monocular estimation method, infants. Okay. First of all, you have to look at the infants. Infants. So the answer will be Mohindra retinoscopy. What is Mohindra retinoscopy? It's very easy. It's in a dark room, okay? In a dark room, all the lights are switched off. Got it? Lights are switched off, and you are slowly moving retinoscope towards the patient. The pupil are dilated, and you will do retinoscopy. That is known as the Mohindra retinoscopy. So it is believed that, okay, and it is also seen, okay, practically that when there is no object visible, the accommodation will be in relaxed state. Okay, the question comes here is why nothing will be visible? The retinoscope light will be visible to the baby. Okay, so there are two forms of light. There are two forms of vision. One is the form vision. Another one is the light vision. Okay, so the light vision is supposed not to affect the accommodation. So because of that reason, the child will only see the light. He will not be able to see the retinoscope. So looking only through the light does not cause accommodation. There should be something, some kind of vision to cause accommodation. So when the retinoscopy in a dark room, when you are doing a retinoscope, when the lights are turned off, everything is turned off, the child is not able to see even the examiner. That is known as the Mahindra retinoscopy. Got it? So that is also the one type of the cycloplegic kind of, okay, though we are not using any cycloplegic drops in the patient, that is also known as a cycloplegic refraction. Yeah, fine. Which of the following term indicates congenital glaucoma diagnosed prior to 3 years of age? Okay, so what is congenital glaucoma? Glaucoma, Buphthalamus is called congenital glaucoma, correct, right? Yeah, it is also called buphthalamus. Hydrophthalamus, yeah, that is also called. All of above or none of above? The answer will be all of above, right? Yeah, it is also called hydrophthalamus or buphthalamus. The cornea will be large, right? Why it is called buphthalamus? Big guy, right? Yeah. So cornea attains the normal diameter by the age of how many years? Okay. How many years? Yeah, 2 months, 6 months, 2 years, or 6 years. At what age the cornea attains the diameter of adult diameter? That will be 2 years. Yeah, everything happens. Most of the things in a child are often near the age of 2 years. Hardly it will be like 3 years also. So when you are measuring a visual acuity of a child, so even the visual acuity, okay, at the age of 6 years, because the child is able to comprehend very clearly. So at the age of 6 years, okay, we take visual acuity to be normal, but the visual acuity of 6 by 6, okay, this is often at the age of 5 to 6 years. But that kind of MCQ is not asked in any kind of exam. So why? Because it depends upon children to children. Most of the children they are not ready for comprehending the visual acuity. When you are asking them to read the visual acuity subjectively, okay, they will not take. But if you take objectively, then yeah, of course, the visual acuity is already developed by the age of 2 to 3 years. That is the minimum difference of power required to cause hypermetropic amblyopia. Yeah, this is an important question. So we have seen what do you mean by anisometropia. Anisometropia means the difference of the power in between the two eyes, right? So anisometropia. What is the main reason of amblyopia? Most of the time, what we call is uh, regarding the optometric cases. Optometric cases. I'm not going to ask the statistical cases. Okay, regarding optometric cases, number one will be the hypermetropic amblyopia. Most of the patients will have hypermetropia. That hypermetropia causes amblyopia, right? Yeah, higher hypermetropia causes amblyopia. And the second one is the anisometropia. So the power in between the two eyes is different. Okay, so yeah, the anisometric amblyopia, what we call, okay, the power in between the two eyes will be different. So the different power in between the two eyes causes amblyopia in another eye. Okay, in one eye having the higher refractive error. So what is the difference? There should be some difference, right? What is the difference of the power that is able to cause amblyopia? The minimum difference 0.25, it doesn't cause amblyopia. 0.75 difference in between the two eyes, that also doesn't cause amblyopia. Even I have 0.275 difference of power in between the two eyes. Okay, the C1 is the 1.25. Yeah, the answer will be C. 1.25 difference of the power in between the two eyes causes amblyopia. Not all the cases, right? In cases of the myopia, 1.25 doesn't cause. The question is hypermetropic amblyopia. You have to look at the question also, right? Yeah. So in cases of the myopia, it varies. It varies. Okay, there is no fixed term. Okay, because in cases of the myopia, in children, what happens? They are able to see the small things very clearly at near. Okay, but they are not able to see things clearly for distance. Because of that reason, myopic patients are very less amblyogenic. Okay, that question. Okay, and this is the practical thing. This is the objective thing. What we have to understand when you are doing, when you are examining a patient also. If you are looking at the myopic patient, there are very less chances that the myopic child will be myopic. Why? What is the reason? Because myopic children, they can see things clearly from here. So myopia happens when the visual acuity is not good for when the vision, not only visual acuity, when the vision is not good for distance, not good for near. Hypermetropia, what happens? The vision will be Yeah, the vision should be restricted for distance as well as from near. That is the reason hypermetropic children are more likely to be like. So, what is the drug of choice for refraction? Cyclopedia refraction in children? Tropicamide, cyclopentolate, homatropine, atropine. So, in a clinic, what do we use tropicamide? No, it doesn't. Okay, no, it doesn't cause so much of cycloplegia. So, most of the time, we're using cyclopentolate hydrochloride. Okay, in only some of the cases where cyclopentolate and tropicamide are not given because of the neurological things like Down syndrome, we are using homatropine. Atropine we don't use nowadays. Okay, homatropine also, well, in some of the cases, tropicamide it doesn't cause so much of cycloplegia. That's why we use cyclopentolate hydrochloride. Along with cyclopentolate, we mix tropicamide and phenylephrine. Yeah. So the answer is the B. Okay. Not only cyclopentolate, what we use the combination. Two drops. Okay. One is a cyclopentolate hydrochloride plus tropicamide plus phenylephrine. Yeah. Those things we use. Okay. Not only tropicamide. Tropicamide separately we don't use. We are mixing tropicamide with cyclopentolate hydrochloride. Answer is B. Okay. This kind of MCQ we have to write the answer B because cyclopentolate is the main thing. Yeah. It differs. Okay, so when you are choosing a cycloplegia for children, so if you go towards the Western countries when the people are white, white people, the iris is very brown. Okay, light brown. In those children, even smaller doses of the drops like cyclopentolate 0.5% or tropicamide also. Okay, they are easy to cause cycloplegia. But if we come towards the darker people, the cycloplegia requires slightly stronger. Why? Because of the color of the pupil, because of pigments. Okay, okay. So the astigmatism up to how much diopter is common in children up to 2 years of age. So after 2 years of age, how much astigmatism do the children have? Average, okay, average. And not average, yeah, astigmatism up to that is common, sorry. So the question, look at the question, okay? It's a very tricky question. Up to how much astigmatism is common in children? Common, okay? So the question wants to tell you, what the questions want to tell you is, up to how much astigmatism do the children have, and that will not cause amblyopia. That is correct. The question is like that. The question up to 2 years only. Okay, up to 2 years. I'm not telling about more than 2 years. The question previously that was so this question after 2 years of age. Okay, that can cause hypermetropia. So this question, what is the amount of astigmatism up to 2 years of age? Okay, that is very common and that will not cause amblyopia. Most of the cases. The answer is up to 2 diopter. Yeah, astigmatism up to 2 diopter because with the rule astigmatism, the eyelids are tight. Same thing. Okay, the cornea is not developed properly. The cornea attains its structure by the age of 2 years. Adult structure by the age of 2 years. Okay. So the refractive error of a 4 years old child. Look at the refractive error of a child. In the right eye, he is having 0.75 refractive error, and the left eye is having 7 refractive error. Myopic patient, right? So this is a cycloplegic refraction. Okay, what is the first state of treatment for this patient? So you will be giving glasses to this patient, 4 years old, okay? Or you will wait till the age of 6 years. He's 4 years old. We can wait for more 2 years till the patient becomes emmetropization. After emmetropization, we'll see at the age of 6 years. Then only we'll decide whether we have to give glasses or we have to give contact lens or anything. Or you will prescribe contact lens for this patient because look at the difference of the power. In the one eye, you'll be having 0.75, other eye you'll be having 7. The thickness of the glasses will be different. Okay, so it's better we give contact lens like this, or you'll simply perform the axial length and keratometry. Okay, so in this question, this is a kind of practical question. Okay, so it's better if you open your mic and tell me the answer for this question. Okay, can you do that, everyone? Yeah. So what do you think?
Sir, B.
The prescribing contact lens.
Yes, sir.
Okay, why? What is the reason?
Because left eye is high myopic.
Hmm.
Uh,
Okay. Any other? Any other student? Okay, fine. So I'm telling you one thing. So do you know about Knapp's law? What is Knapp's law?
no, sir.
KNA KNAPPS Knapp's LAW law. Okay, you write down these things. You have to read about this. Okay, KNAPPS Knapp's LAW law.
Okay.
Uh, K is silent. Okay, so Knapp's law. There is a thing called Knapp's law. So okay, so whenever you are prescribing a patient, okay, this question, okay, it may not be asked. It may not be asked in your exam, okay, but during your practical days must important thing. Okay, this is very very important thing. So the first step of treatment of this patient, okay, we will not prescribe glasses directly. We will not prescribe contact lens also directly. We will perform axial length and keratometry for this patient. Yeah, the answer will be C. Why? What to perform axial length and keratometry? Because see, this is a clear case of anisometropia, right? Yeah, it's a clear case of anisometropia. It's a myopic case, right? So the first thing is it's a myopia case. So before I think 2 or 3 slides, okay, I told you myopia cases are very unlikely to be amyloidogenic, right? And the second thing, so what happens? Anisometropia. There are two types of anisometropia. Number one anisometropia, axial anisometropia. And the second anisometropia, that's a refractive anisometropia. So what is the reason of anisometropia? Because of the difference of the axial length of the two eyes, the child will be having anisometropia. That is clear, right? Axial length. And the second one is that because of the difference of the curvature of the cornea or the curvature of the lens, refractive index of the lens, the child will be having anisometropia. Because of these two reasons only, the child will be having anisometropia. Got it? So, first of all, we need to find out what type of anisometropia is this. Then only we can go to our contact lens service. So if the patient is axial anisometropic, we have to go towards the glasses. If the patient is refractive anisometropic, better to go towards the contact lens. Got it? Practically, I have seen a patient who was having minus 0.50 in one eye and 8.25 in another eye. Gave him glasses. He was 5 to 6 years old. There was diplopia and the thickness of the glasses. But what happens is when there will be difference in thickness of the glasses in between the two eyes, the size of the images will be different. Yeah. The first thing that comes to our mind is the same thing. When the difference in thickness of the two glasses will cause difference in the size of the images. But that is the wrong thing. Why? The Knapp's law proves everything. If you read Knapp's law, what it says is if the difference in between the axial length in between the two patients, in between the two eyes is there, okay, there will be no difference of the size of the images of the retina. But if refractive kind of thing, then of course it will cause a change in size of the images. So refractive, you have to give contact lens. Already the cornea is not distributed easily because of that reason. Okay, you have to give contact lens if the patient is refractive and isometropic. Okay, possibly you have to do axial length. and keratometry to find out whether the patient is axial anisometropic or refractive anisometropic. So accommodation is properly attained at the age of a new one at the age of how much months? I think it's an old question. 10 centimeter, okay, 10 centimeter, yeah, accommodation will be obtained at the age of 3 to 4 months. The answer is 3 to 4 months. So the option given here is 4 months, okay. So we have the following with the clinical sign of pseudostrabismus in pseudostrabismus. You know, right? This is also an old question, I think. Which are the following with the clinical sign of pseudostrabismus? Prominent epicandral fold will be there, telecanthus will be there, broad nasal bridge will be there, or all of them. Okay, all of them. Yeah, telecanthus means the cancers are located very far from each other. The nasal bridge is broad. There will be prominent epicandral fold. Okay, so all of these cause pseudoesotropia. Pseudoesotropia. So all of the above. Yeah. So which of the following statement is wrong about pinhole? Yeah. So this is not regarding pediatric optometry. It is regarding refraction, right? So which of the following statement is wrong about pinhole? Pinhole, if it is less than one diameter, it impairs the image quality. Is it true? Okay, what is the size of pinhole? You know that, right? Okay, fine. If the pinhole is less than 1 millimeter diameter, it impairs the image quality. Is it true? Yeah, is it true? If the size is less than 1 millimeter, then there will be diffraction. We know, right? Diffraction. Diffraction causes impairment in visual quality. So this is true. It abolishes the need for the eye to focus. Yeah, of course, only the parallel rays of light will be going. Because of that reason, it abolishes the need for the eye to focus. It is also true. It increases the depth of focus. Yeah, of course, it increases the depth of focus because the peripheral rays are cut off. It increases the depth of field also. Yeah, it improves emmetropia of less than 6 diopter. When you are putting pinhole in front of a patient's eye, even if he is having refractive error, he is able to read, right? So it improves emmetropia of how much?
4
4
diopter.
Yeah. So the fifth one is wrong, right? Yeah. So the wrong is E. Yeah. So which of the following statements are true about clinical refraction? Accommodation results in a more myopic patient. Yeah, if the patient is myopia, of course you will be having in a more myopic prescription. Okay, it's given like that. If you are overcorrecting a patient, yeah, you will be having accommodation. Yeah, and if the visual acuity is measured binocularly for distance and near, visual acuity is not measured binocularly initially. Okay, first of all, it is measured monocularly. Then occlusion is the treatment recommended. So the second one is wrong, right? Second one is wrong. Occlusion is recommended for patient with nystagmus to reduce the ocular movement. This is also wrong because when you are occluding a patient of nystagmus, the occlusion increases. A high minus lens over the non-examining, that is also wrong. A high minus lens over the non-examining of the patient with nystagmus, it increases. Okay. The recent wearing of gas permeable lens may keep, yeah, that is true. So if you are using a RGB lens, it causes corneal rapids, okay? Corneal warpage it causes. So because of that reason, there will be some irregularity in the cornea. So because RBG, this rigid gas permeable lenses, they have to rest on the cornea. They have to induce some amount of pressure on the cornea. So they cause some change in this cornea, right? So the first and E are right. So what about nystagmus? Okay, the option C and D. Okay, there is something in cases of the nystagmus. How you will, yeah, in a practical exam, not in this kind of theory exams. In a practical exam, people may ask you this question. Suppose there is a nystagmus patient. So how you will take visual acuity? How will you take visual acuity in this patient? So how will you take? Did you have posting in clinic?
Yes, sir.
Okay, so I will take visual acuity in a nystagmus patient.
Without occluding.
Hmm. Without occluding, that will be a binocular visual acuity. So if you want to take a monocular visual acuity in a nystagmus patient, because the vision is not same in two eyes, right? Okay. So see the look at the option. Okay, a high minus lens over the non-examining of the patient. It's written like that. So this is if this is wrong, then the answer will be opposite. A high plus lens. So when you are occluding the other eye, you have to use the high plus lens. You can use +5, +6 like that. Okay. You have to relax the accommodation in that eye. Yeah. Why? Why you have to relax that accommodation? Because if you completely block that eye, okay, the rate of the nystagmus increases because the patient always tries to find the null position, okay, where he is able to adjust his head, okay. So abnormal head posture, okay, you have to maintain the abnormal head posture. So if you are not uploading the eye, there will be. See, I told you that time also there are two types of vision. One is the firm vision and one is the light vision, right? If you get some light from the other eye, so even if you get some light vision in the other eye, the abnormal head posture decreases. So if the abnormal head posture decreases, the visual acuity will be better. So you have to use plus lens in front of the other eye. So which of the following case does not require binocular vision? Direct swing, it requires. Direct rod, it also requires. Bikram test, what's for that test? Diagonal static glasses test. Bikram doesn't require, right? Because Bikram you can monocularly also. When you are taking visual acuity in a child, okay, the last step, okay, what do we do? We use Bikram test so that the red is better or green is better like that. So monocular we have to do Bikram test. Binocular also we can do Bikram test. Binocular also we can do. But monocularly it is done. Okay, most preferably. So it doesn't require the binocular vision. So okay, if the question asks binocular Bikram balancing, then only you have to talk about the binocular thing. Otherwise, Bikram test doesn't require two eyes at the same time. Fine. So the Bikram test. So what is diagonal studded glasses test? You know why it is used? Microtropia. To diagnose microtropia. Microtropia. When the tropia is smaller than 5 vision diameter, in those cases, diagonally studded glasses are used. And there is another thing, okay, double malax rod. In which case double malax rod is used?
Cyclotropia.
Correct. Yeah. Mm. Okay, regarding refraction in children, which of the following statements are false? Myopia is more common in hypermetropia in children, in babies. Okay, this is wrong because most of the children they have hypermetropia. Why? Because the eyeballs are smaller. Simple answer. Simple answer. Okay. So refractive myopia can occur if there is more than 1.25 diopter of hypermetropic and asymmetropia. Yeah. In one of the MCQs, okay, we have read this thing. Increased accommodation is used by the children to overcome uncorrected hypermetropia. Yeah, that is also correct. So accommodation is used by the children to overcome uncorrected hypermetropia. So when they are using increased accommodation, the convergence is also high. So in those kind of children, okay, they are very easily to develop esotropia, refractive esotropia, refractive accommodative esotropia. Yeah, myopia tends to progress as the child grows older. Yeah, that is very often, okay, because the eye length, okay, the eye axial length also increases because of that reason. Myopia also increases. Correction of hypermetropia can reduce exophoria. See, look at the fifth term. Okay, correction of hypermetropia can reduce exophoria. This is a very tricky tackling kind of thing. Hypermetropia, what happens because of hypermetropia? The eyes are relaxed. Okay, if you are correcting hypermetropia, the eyes are relaxed. Because while correcting hypermetropia, you have to give the plus lens. The plus lens always relax the accommodation. So when the eyes are relaxed, okay, It induces exophoria. It doesn't, because it reduces the convergence, right? It reduces the convergence, because of the reason it induces the exophoria. So the answer is wrong. Correction of hypermelia can reduce exophoria. That is wrong. Okay. Yes, done. So anything regarding this PPT you want to ask?
No, sir.
How we can take history for child? What
History of a
are
child?
the things that includes? Yeah.
Yeah, history of a very, yeah, history of a child. It depends upon the see. What I want to tell you is it depends upon case to case. So you have to look at the patient, whether the patient is neurological patient, whether the patient is an active patient, or they have come for a regular examination. Depends upon what type of patient is that. But no, what I want to say is commonly what I want to tell, when you are starting the history of a patient, okay, initially you'll go towards the age of the patient, right? Okay, and the complaints also you have to ask first of all what the patient is having, what is the complaint, whether the parents have come with a complaint of strabismus or reduced vision acuity or anything like that. You have to ask the mother, age of the mother and father. Okay, what is the difference? Okay, so if the age is greater, if the age of the mother is greater than 35 years, there is more likely chance they will be having some neurological problems like Down syndrome. Okay, so about the marriage status. Marriage status, why it is very important asking the marriage status, because of the consanguinity. Okay, if the blood group is same, if they are from the same family, the blood group is almost they are from the same blood, then very high chance that they will be having some neurological problems. Okay, and whether the mother, okay, she was taking any contraceptives or any medicines when she was pregnant. She had some diseases. Whether the mother had some diseases when she was pregnant, she had typhoid, she had tuberculosis, she had habit of drinking, many things. Okay, whether she was taking any medicines or something like that. Okay, and in 1970s, okay, in 1970s, in Germany, okay, what happened? There was a very in Germany. What happened? There was very important thing happened. Okay, most of the children, or most of the babies, okay, they were born in that time. Okay, those babies have very small hand, very small legs. Okay, but the belly was large and the head was also large. Like you have seen seal, seal, seal in the sea. In the sea, the seals, okay, they can't walk. They are crawling very much big size. Okay, so the babies were born like that only. Okay, they were like a pea. Okay, and the research was carried out. Okay, to see, okay, why these kind of children are getting born over there. So they find out finally is that they were taking some kind of medicine, aspirin or some kind of medicine they were taking. Not aspirin exactly. I think I forgot the name. They were taking one medicine to avoid pain when they were pregnant. Most of the women, okay? So they were having pain when they were pregnant. So to avoid that pain, they were taking this vomiting sensation also they were having. So to avoid the pain, vomiting sensation, they were taking that medicine. Most of the women, okay? So that medicine, okay, after that, the medicine was stopped, okay? After the medicine was stopped, there were no cases like that. So taking up medicines when the woman is pregnant is very important. Is very sorry, harmful. So history should also be there. Okay, most of the things are regarding the parents. Okay, any medicines, alcohol, habit, cigarette, TB, diseases like that. Consanguinity is also very important. Okay, and the other thing, the developmental milestones. Okay, you have to ask about the developmental milestones, whether the neck holding was in proper time, whether the speaking was in proper time, walking was in proper time. Okay, at what age neck holding should occur? At the age of 6 months, 7 months, like that, right? The baby should sit at the age of 9 months. 9 to 10 months, the baby should be able to sit on himself. Okay, at the age of 12 months, the baby should be able to walk. Okay, these things. Uh, These are regarding the developmental milestones. Whether any neuroimaging was done to the patient or child or not. Okay, these things also you have to ask. I have a PPT regarding the history taking. Okay, I have made that PPT also. I'll send you that. This PPT also I'll send you. Very, very, very deep thing regarding the history taking. So many things. If you want to know about the particular thing regarding history taking, then you can ask me. Okay.
Yes.
Wait, what is the patient, the child, okay? The child is whether fixing or not, okay? How to examine a patient, how to examine a patient is also a very long term, okay? When you are taking visual, when you are seeing the patients have a complaint that the child is not able to see, okay? There are some of the cases where the child is malingering, okay? He is telling, okay, I am not able to see anything. When you comes to a clinic, some of the children are very, very smart. Okay, very smart. Okay, when you are showing them the larger letters, okay, they are reading. When you are showing them the smaller letters, they know exactly where to stop. So they will stop there only and they will not read. So in those cases, how will you find out? And when you look at the fundus, when you do the refractive error examination, okay, there will be nothing. So what is the reason the child is not able to read? That's malingering case, right? So how do you differentiate a malingering case and actual visual acuity difference? Okay, that's also a very deep question. So in those cases, first of all, you have to what you have to do is you have to use the prism also, prism method, 10 prism base out test or 10 prism base out test you can do whether the and look whether the patient is fixing or not. Okay, observing the fixation is a very important thing. Okay, that thing we can use in children also, in babies also, whether the child is fixing or not by using the 10 prism base out test, base up test. Okay, that is the thing. And the second thing what you can do to differentiate a malignant patient and a normal patient is that so block one eye, right? Occlude one eye, and the other eye you have to put +4 lens. So once you put +4 lens and give him the visual acuity of 6/9 or like that, right? So and you take out and ask the patient to read, and the patient will see everything blurred, right? And the patient will immediately say, even if the patient is lying, the patient will immediately say, so everything is blurred now. He will say, and then you put a one lens, other lens you put, okay? And then they ask the patient, very, very less power you put, okay? After that, you have to put either plano lens or 0.12, okay? There is one lens in the child frame, 0.12. So you are not using that lens all the time, right? So in that cases, in malingering cases, you can use that 0.12. You put that 0.12 and ask the patient to read. Yeah. If the patient reads, okay, that's the case of malingering. Or you can put zero power lens also, plano lens also. Yeah. And regarding other thing, any important thing here I have to ask. The HFTV task, you know, right? The mirror image is same because of that reason you are using HFTV. Then liquidity is very important in France. Preferential looking test. This is very important. And you are the only one, right? How many people are there? When you are having exam,
Mm,
Sir,
Then
upcoming Monday.
this Monday only you are having. Okay, all the best. Okay, very
Thank
much. All the best to you. So how many seats are there?
three.
on 10, sir.
10 seats. Which
Yes, sir.
university?
Pokhara,
Oh, Pokhara University.
sir.
Okay, so you'll be having your courses in Pokhara or in Kathmandu teaching this
Tilganga or Himalayan. 7.
Telangana.
Yes, sir.
Okay, okay, that's good. Don't worry, everything will be fine. This you will be given the basic questions. Basic questions you will be given. There is one thing. Okay, you can see my slide, right? Slide. I'm giving you one thing. Okay. So have you seen these kind of MCQs? This in optics and refraction. This do you have this? Can you see my screen?
Yes, sir.
Do you have this self test in optics and refraction?
No,
No,
sir.
sir.
No, you don't have?
We don't have this.
Okay, so if you go through this, okay, so this is the international thing, MCQs. Very important. Basics, properties of light, refraction, the practical things, there are very less practical things. So the basic things like, okay, I'll tell you, okay. Yeah. Properties of light, optical radiation. See, even if you ask me these things, okay, if with regard to optical radiation, whatever, I forgot most of these things. Because every time I'm going to the clinic, we are not reading the books now, right? So we are very familiar with the practical things, but these kind of theoretical things, okay, we have most of the things that are forgotten. So basic things I'll ask you, okay? So tell me one basic thing. What is the, you are taking color vision in a child, in a patient, right? Most of the patient you are examining the color vision by that Ishihara chart. You tell me what is the proper distance of examining color vision?
Sierra chart,
Yeah,
75 centimeter.
yeah, 72 to 75 centimeter, right? These basic things, okay, most of the time, unless we read, okay, that doesn't come to our mind. So most of the people will say 30 or something like that, right?
Yes.
You are smarter, so you know 75 centimeter. 72. 72. I read somewhere it's around 72, I think. So even if I read 72 centimeter, when I'm giving a patient, I'll give you a 30 centimeter only, right? So I'll send you this also. There are different topics. See, this MCQ is here only pinhole. Contact sensitivity, fire fringes, what is buyer fringes, stereovision testing, okay? These are the basic things. I have some papers from my master's from Chitkara University. I don't know whether these papers are with me or not. Okay, if I have, I'll send you those papers. Okay, I may not be having the answers of those papers. Basic things. You will be asked basic things. You will not be asked so much of hard questions like what are the treatments of amblyopia. Okay, those kind of binasal occlusion, this therapy, that therapy. Okay, those questions you won't be asked because those things will be included in your syllabus, not in your exam. If someone is giving you those kind of questions, then what to say? Yeah, because when appearing for an exam, for a master's exam, okay, so the basic things that should be asked. Okay, the one thing okay that should be asked during the interview. You will have interview also, right?
No, sir.
You won't be having only the written exam.
Yes, sir.
Okay, then fine. So in a master's exam, okay, there will be two things only: one written exam and one viva or kind of viva. Okay, interview kind of thing. In interview kind of thing, the question that should be asked is, so what is the project that you are trying to what is the project okay that will be taking in your masters? This is the thing, one question because the important thing is the project. One topic should be there. If you don't have Viva, then fine. Most of you have done this bachelor's from Nepal only.
India,
India, which university?
Uttarakhand,
Which one?
Uttarakhand University, Dehradun, sir.
There are in Dehradun also there is optometry.
Yes, sir.
Uh, Dehradun. So you are very new ones. Recently you are passed out.
No, sir. 2 years ago.
Fine. After my bachelor's, I did fellowship. Immediately, I did fellowship. After fellowship, I did job for 2 years. There was 3 years of gap. Then I joined masters. Masters is not so much compulsory. So if you, in the abroad countries, whatever is okay, directly after bachelor's, they go towards the PhD. So the important thing is research. Okay, if you are going towards the master's line, Research. Research is the main thing. If you have papers, if you have papers published in international journals of around two, three, four like that, then you can apply for PhD and you can directly go to the European countries. Okay, that is very easy. Only after bachelor's also it's very easy. Okay, and the second thing, there is for PhD if you are interested, because people are interested for PhD, that's why they do masters. Okay, so masters. I was doing my job. I didn't have anything to do, only the job only. Okay, because of that reason, I joined masters. People have choices, they have different choice. And after masters, I had a chance to go Netherlands, Maastricht University for PhD, but I didn't take that. So everything is a choice for so you people. I think so everyone is interested for PhD, right? Because of that reason, you are doing masters or anything else. Okay, I think I'm not audible. Fine. Then today we'll Saraswati, Pavitra, Saraswati, Susmi. These three things, right? So I think this is the last class today. So I want to know the names. I forgot the names. What is the name? Pavitra. What is
Chaudhary,
the full
sir.
name?
Chaudhary.
Chaudhary. Yeah.
Yes,
So where
sir.
are you from?
I am from Dang, sir.
Dan.
Yes, sir.
Where in Dan?
Dang Gorai.
Well, I'm also from Dan. Okay.
Yes, sir.
In Gorai, I have one clinic,
Name
revision eye care.
New Vision Eye Care.
Revision eye clinic.
New Vision.
R-E,
Oh,
In Gorai, I have one clinic. In Tulsipur, I have one clinic. So I'm planning to start one clinic, a nice clinic in Gorai. So good. Next time we'll do a collaboration.
okay, sir.
Fine. So Saraswati,
Yes, sir.
yeah, your name Saraswati.
BC
Saraswati from
from Kathmandu.
Kathmandu. Okay, fine. Saraswati and Susmi. Susmi?
Sir Susmita Bhattrai
Susmita, what I? Susmi is
from
his name.
Bhairava.
From
Bhairava, sir.
Bhairava. Okay. Susmita Bhattrai.
Yes, sir.
Okay, fine. Nice to meet you all. Okay. All the best for you. Hope you will crack your exams. Don't worry. It will be very easy. Okay.
Yes,
Okay,
sir.
sir.
Thank you, sir.
Okay. All the best. Yeah.
Sir, can you send that PDF in our Gmail account?
Yeah, sure.
Okay, so we'll
So,
send Gmail.
yeah, fine. Send me a Gmail account. Okay. So you people are in the WhatsApp group also, right?
Yes, sir.
There's a WhatsApp group, right? You are in that WhatsApp group also.
Yes, sir.
Okay, fine. Then I'll give you a message after sending you the
Okay,
open
sir.
masters optometry is there, right? Yeah. You send me the mail.
Yes, I send it to you. Here and in chat.
Okay. Where is the chat? Yeah. Let me what I 97 @gmail.com. Fine. I'll send there. So you can circulate among your friends, okay?
Okay, sir. Thank you, sir.
Welcome, yeah. All the best. See you.
Thank you, sir.
Welcome. Yeah, you can call up now. SUSMIDHATARAI @gmail.com.